Apicon highlights continued. Insomnia. The approach to treatment of insomnia. We have to decide, is it acute or short-term insomnia or chronic insomnia? Acute, we have to find out if there's any trigger or short-term stressor, and which is likely to be resolved soon. Then we consider using the Z drugs. This is for 3 to 7 days. The Z drugs are zolpidem, zopiclone, zaleplon, and esopiclone. If there is a resolution, no further treatment is required. If there is no resolution, we consider the treatment for chronic insomnia. The first line approach is a non-pharmacological approach of cognitive behavioral therapy. This is given for 6 to 8 weeks, and then we review in 4 weeks. If it's unresolved or the CBT is not available, we consider adding pharmacological treatment. If it is resolved, there's no further treatment needed. The components of CBT therapy are stimulus control, sleep restriction, sleep hygiene, cognitive therapy, and relaxation therapy. The pharmacological treatment is given for approximately 4 weeks, including the Z drugs, benzodiazepines like triazolam, estazolam, temazepam, florazepam, and quazepam, the DORAs, which are suvorexant and lemborexant, melatonin receptor agonists like ramelteon, and antidepressants like doxepin. Steroid use. We must know the equivalent doses of various steroids. Compared with hydrocortisone, the equivalent dose of glucocorticoids are 20 milligrams of hydrocortisone and 5 milligrams of prednisolone, 4 milligrams of methylprednisolone, 6 milligrams of deflazacort, and 0.75 milligrams of dexamethasone. Dexamethasone is the longest acting, and that works for more than 36 hours. The intermediate acting ones are prednisolone, methylpred, and deflazacort, which acts for 12 to 36 hours. And hydrocortisone acts less than 12 hours. Anti-inflammatory potency relative to hydrocortisone is maximum for dexamethasone, which is 30 times more potent than hydrocortisone. Deflazacort is 3 to 4 times more potent, methylprednisolone 5 times, prednisolone 4 times. The mineralocorticoid activity for hydrocortisone is the maximum, it's 1. Prednisolone is 0.8, methylprednisolone 0.5, 0 for deflazacort, 0 for dexamethasone. Deflazacort is a synthetic corticosteroid. There's an insertion of methyloxazolin ring structure of prednisolone 21 acetate. After oral administration, deflazacort is rapidly and completely absorbed in the intestinal tract with a Tmax of 1 to 2 hours. There's a high binding affinity to glucocorticoid receptors. There's elimination of deflazacort metabolites by the kidneys in 24 hours. The dosage depends on the clinical condition. A maximum study dose is 120 milligrams a day. Maintenance dose for most conditions 3 to 18 milligrams per day. The key messages would be it causes lesser hyperglycemia, lesser weight gain, lesser dyslipidemia, lesser hirsutism and Cushing severity index, lesser effect on the BMD, and less tendency to affect lean body mass, and lesser risk of growth retardation in pediatric patients, and there's lesser HPA axis suppression. It's approved for most of the conditions that the other steroids are used for. Sodium balance. Hyponatremia is when the sodium is less than 135, hypernatremia if it's more than 145, hyperosmolality if it's more than 295, hypoosmolality if it's less than 280 milliosmoles per kg of water. The types of hyponatremia are hypotonic hyponatremia, in which the plasma osmolality is less than 280. Serum osmolality and sodium are both low due to excess water that is not excreted. It is the most commonly encountered type of hyponatremia. Hypertonic hyponatremia is when the plasma osmolality is more than 295. The serum osmolality is high, serum sodium is low, as in hyperglycemia, administration of IV immunoglobulin. The water shifts from the intracellular to the extracellular compartment. Isotonic hyponatremia, the plasma osmolality is between 280 and 295. You see it in some urological and gynecological surgeries due to absorption of sodium-free irrigation solutions such as mannitol, sorbitol, or glycine. There is no shift of water from the intracellular space. Pseudo-hyponatremia is rare and is avoided by measuring sodium by direct ion selective electrode. Serum osmolality is calculated by 2 into sodium plus glucose by 18 plus BUN by 2.8. The osmolar gap is measured osmolality minus a calculated osmolality. Pseudo-hyponatremia is a corrected sodium. You calculate the corrected sodium by measured sodium plus 1.6 times the measured glucose minus 100 divided by 100. So for instance, if the blood sugar is 788 and the serum sodium is 122, the corrected serum sodium is 122 plus 1.6 into 788 minus 100 divided by 100, which is 11. Therefore, the true serum sodium would be 122 plus 11, which is 133. The diagnostic approach to hyponatremia. If the serum sodium is less than 135 and if the osmolality is more than 280, you consider translocational hyponatremia, hyperglycemia, mannitol infusion. If the osmolality is less than 280, you check the urine osmolality. If that is less than 100 milliosmoles per kg, you consider psychogenic polydipsia, water intoxication, and reset osmostat. If the urine osmolality is high, more than 100, you see, is the patient edematous or having any ascites? Yes, if it's present, you consider CCF, cirrhosis, and renal failure. If there is no edematous state, you consider, is there volume depletion or no? If there is volume depletion and the urine osmolality is low, less than 25 millimoles per liter, consider extrarenal losses like GI losses. If it's more than 25 millimoles per liter, diuretic use, salt-wasting nephropathy, mineralocorticoid deficiency, and osmotic diuresis are considered. If the volume depletion is absent, consider renal failure, hypothyroidism, glucocorticoid deficiency, post-op state, spinal fusion, pain, stress, or nausea, positive pressure ventilation, exogenous DDAVP. If that is not there, you measure the urine sodium at more than 25 millimoles per liter, you consider SIADH. Less than 25 millimoles per liter, you repeat the algorithm. The treatment of hyponatremia. In acute hyponatremia, if you have encephalopathy, delirium, seizures, coma, emergency correction is required. Hypertonic saline at 1 ml per kg per hour until clinical improvement, and serum sodium increases by 4 to 6 milliequivalents per liter. Administer a bolus of 100 ml of 3% saline in those with a seizure or with co-administration of IV furosemide of 20 to 40 milligrams if there is volume overload. Adequate ventilation is necessary. In chronic hyponatremia, there would be headache, lethargy, unsteadiness, nausea. You correct it gradually. Restrict the fluid to less than 1 liter a day. Identify and treat any reversible cause such as SIADH. AVP receptor antagonists can be given. Consider other treatments like clozapine and demeclocycline. Hyponatremia treatment algorithm would be: severe neurological symptoms are present, give 3% saline until the symptoms are improved. If it's not present, you just work on the diagnosis. Do not give salt or saline if there's cardiac failure or cirrhosis. Instead, you just do fluid restriction. In SIADH, do not give saline. You fluid restrict them. You consider salt tablets if the etiology is not quickly reversible. If the urine osmolality is more than 500, consider adding a loop diuretic. If there is a reset osmostat, treatment is not indicated. If there's any form of volume depletion, do not restrict the fluid. You have to give them plain normal saline. If there's primary polydipsia, normalize the fluid intake. How is tolvaptan started? Tolvaptan should be started in a hospital setting for monitoring sodium during the dosage titration phase. The drug is started at 15 milligrams once a day and can be titrated up to 60 milligrams daily without fluid restriction. Once his patient's symptoms improve, he can be discharged in 2 to 3 days on a fixed dose of tolvaptan. It is indicated in patients with euvolemic and hypervolemic hyponatremic patients. It should not be used in hypovolemic patients. Diagnostic approach of hypernatremia. Fluid volume status is assessed by clinical examination. If the patient is hypovolemic, there is a loss of water more than the sodium. You check the urinary sodium if it's more than 20 milliequivalents per liter. Renal losses, diuretics, glycosuria, and renal failure considered. If the urine sodium is less than 10 milliequivalents per liter, consider extrarenal losses like GI, vomiting, diarrhea, excess sweating, respiratory loss. The treatment is with saline and then hypotonic solutions. In euvolemic hypernatremia, there is only loss of water. Check the urinary sodium. If it's more than 20, consider renal losses like diabetes insipidus, central and nephrogenic. If it's less than 10, consider extrarenal losses like insensible losses, skin and respiration. Treatment is water replacement, 5% dextrose at 1 to 2 milliequivalents per liter per hour, plus or minus vasopressin for central diabetes insipidus. If there is hypervolemia, there's a gain of water and sodium. Check the urinary sodium. It will be more than 20. Iatrogenic causes are hypertonic soda bicarb, salt tablets, hypertonic solutions. Mineralocorticoid causes would be primary hyperaldosteronism, Cushing's, and adrenal disease. Hypertonic dialysis, hemodialysis, peritoneal dialysis, and the treatment can be done with diuretics plus or minus dialysis. Ascites. What is ascites? It's the accumulation of fluid in the peritoneal cavity. It's caused by increased portal pressure, decreased plasma osmolality due to hypoalbuminemia and decreased renal blood flow, and sodium and water reabsorption. Peritoneal infection, metastasis, mesothelioma, sarcoma, or pancreatic disease. In ascites, we see the total protein. If it is less than 2.5 and the SARG is more than 1.1, there is portal hypertension. It happens in cirrhosis, portal vein thrombosis, late Budd-Chiari syndrome. If the SARG is less than 1.1, it's non-portal hypertension. We consider nephrotic syndrome. If the total protein is more than 2.5 and the SARG is more than 1.1, we consider chronic heart failure, constrictive pericarditis or tamponade, IVC obstruction, and early Budd-Chiari. If the SARG is less than 1.1, we consider malignancy, peritoneal carcinomatosis, TB, serositis, and pancreatic ascites. Urine or chylous ascites may also cause a SARG of more than 1.1. What is the definition of refractory ascites? Persistence of ascites despite sodium restriction and maximum tolerable dose of diuretics. Refractory ascites is defined as ascites that does not recede or that recurs rapidly after therapeutic paracentesis despite sodium restriction and maximum tolerable dose of diuretics, that is spironolactone 400 milligrams a day and furosemide 160 milligrams a day. There are two types: diuretic resistant, diuretic intractable ascites. The resistant type ascites is not responsive to intensive diuretic therapy and dietary sodium restriction. In the diuretic intractable ascites that is refractory to treatment due to the development of diuretic-induced complications. The modified diagnostic criteria for refractory ascites includes treatment duration. The patient must be on intensive diuretic therapy, spironolactone 400 milligrams per day and furosemide 160 milligrams per day for at least 1 week, and on a salt-restricted diet of less than 5.2 grams per day. Lack of response means the weight loss of less than 0.8 kg over 4 days and urine sodium output less than the sodium intake. Early ascites recurrence is the reappearance of grade 2 or ascites within 4 weeks of initial mobilization. Diuretics-induced complications include hepatic encephalopathy, renal impairment, an increase of creatinine more than 100% to a value of more than 2 milligrams per deciliter in patients with ascites responding to treatment. Diuretic-induced hyponatremia, if there's a drop in sodium more than 10 millimoles per liter or to a serum sodium of less than 125, or if there's diuretic-induced hypo or hyperkalemia, change in the serum potassium to less than 3 or more than 6 despite appropriate measures. Rule out mixed ascites. In peritoneal tuberculosis, the SARG-ADA of 30 to 45 is more than 90% sensitive in tuberculous ascites. Underlying heart failure, serum pro-BNP more than 364 picogram per ml, cirrhotic cardiomyopathy and LVDT should be ruled out with a 2D echocardiogram. Peritoneal carcinomatosis, microscopic examination for malignant cells, tumor markers in ascites fluid, tumor markers like CEA, CA15.3 and 19.9. 30 ml of fluid is sent 3 times. Spontaneous bacterial peritonitis, neutrophil count is more than 250 cells per cubic millimeter. The treatment, first line would be large volume paracentesis, usually LVP more than 5 liters in combination with 8 grams per liter of albumin. Albumin is given to the patient to mitigate the risk of post-paracentesis circulatory dysfunction. The rate of infusion of 20% albumin is 2 ml per minute with a 50% dose immediately after the paracentesis and 50% 6 hours later. Albumin is superior to plasma expanders like dextran 70, saline, polygylene, and terlipressin, noradrenaline, etc. Vasoconstrictors and vaptans. Outpatient terlipressin infusion for 28 days decrease the number of therapeutic paracentesis and the volume of fluid removed. Midodrine, an alpha-1 adrenergic agonist, has been shown to suppress the RAS activity and improve natriuresis. 5 milligrams thrice a day, increase the dose by 2.5 milligrams to a maximum of 17.5 milligrams 3 times a day. 1 month of treatment with midodrine, long-acting octreotide, and 50 grams of albumin thrice weekly resulted in RAS suppression and a trend toward better ascites control and improving HRS. Midodrine, along with standard medical therapy, led to better ascites control, no further deterioration of MEL score at 3 months, and improved survival at 1 year in patients with refractory or recurrent ascites. Peritoneovenous shunt or Denver shunt. Peritoneovenous shunt is a connection between peritoneal cavity and the systemic venous circulation via a shunting tube placed subcutaneously connected with a one-way pressure valve. It allows continuous drainage of the peritoneal fluid from the peritoneum into the venous system, mainly the internal jugular vein or the SVC. Alpha pump, automated low-flow ascites pump. It's implanted subcutaneously and pumps ascitic fluid from the peritoneal cavity via peritoneal catheter to the bladder and is discharged as urine. Second-line therapy would be TIPS. The caution would be in people more than 70 years and ejection fraction of less than 60, MEL score of more than 18, child puke class C, platelet count less than 75,000, GI bleed or SPP. A fistula is created between the portal and hepatic veins, an expandable shunt inserted to maintain patency. Prophylaxis. Patients with cirrhosis with variceal bleed should receive prophylaxis for SBP. Patients with cirrhosis and low ascitic fluid protein of less than 1.5 and a bilirubin of more than 3, child puke score more than 9 need to receive primary prophylaxis. Patients having SBP should receive long-term prophylaxis either with oral norfloxacin, ciprofloxacin, cotrimoxazole or rifaximin after the recovery. Long-term would be Norflox or rifaximin 550.